Hello, and welcome to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier, consisting of review articles centered on a major topic important to surgical oncologists. I'm Megan Ashdown, managing editor of this series, and today we'll be discussing the July 2025 issue dedicated to melanoma. Leading our discussion is our consulting editor, Dr. Tim Pollack, professor and chair of the Department of Surgery at the Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editor of this issue, Dr. Genevieve Boland, associate professor of surgery at Harvard Medical School and vice chair of research and surgery at Massachusetts General Hospital in Boston, Massachusetts. Welcome, and I'll now turn it over to you, Dr. Pollack.
Thanks so much, Megan. I'm really excited to be talking to Dr. Boland today, who is a national and international expert on the treatment of patients with melanoma. Welcome, Dr. Boland.
Thank you so much. Happy to be here.
Great. Well, thanks again for doing such a fantastic job amassing a world-class group of authors to put together this issue on melanoma. This field has been fastly moving over the last 10 years with some significant advancements for the patients who suffer from this disease. So to that end, I thought we'd kick off by discussing Dr. Holder's paper on systemic therapy for melanoma. I remember when I was a fellow now many years ago, 25 years ago, there weren't a ton of effective systemic chemotherapy options. I remember it being a treatment that was associated with much toxicity and little efficacy. This article I thought was very, very interesting because it shows just how far we have come when we think about systemic therapy for melanoma. So I was wondering maybe if you could just talk to us a little bit about that, the last 10 years and what have been some of the major innovations and revelations when it comes to systemic therapy for these patients.
Sure. I mean, I think that era of chemo, the era of not very efficient and probably overblown immunotherapy, and by that I mean IL-2 and things that were super toxic with this effort of getting the body's immune system to see cancer, really left the field, as you said, with very few options. And it really was 2011 when the FDA approved two different new classes of drugs. So molecularly targeted therapies, targeting the BRAF mutation, which about half our patients have, and then immune checkpoint inhibitors, which were the sort of the modern new chapter of immune therapies that didn't have a lot of these side effects, would seem to work much better. The interesting thing is that, the two first approvals were around the same time. And so nobody really knew who to use for what. And I think we're still figuring that out. Having new options was amazing, but there were many challenges, I think, in sequencing and who should get what for what kind of disease. I think we've sorted out a lot of that and we continue to kind of iterate. So each of those has undergone some tweaks in terms of combos that are more efficacious, but those two classes are a pretty big branch point. And there's now clear data that at least for stage 4 disease, getting immunotherapy first is better. For stage 2 and 3, that's to be determined. But I think it's been really exciting. I think there's just an explosion of interest if you look at publications and grants and drugs. And I think we're still figuring out now how to identify the right people for the right treatment.
Great. Yeah, well, so that's a great point. So I know in this article, it highlighted several different immune checkpoint inhibitors and, their different classes and some of the recommended treatment options. So I'm wondering if you could just help the practicing surgeon better understand, the different drugs that are available, whether it be like Pembro or Ipi or Nivo. How does one, kind of figure out this kind of hodgepodge, if you will, of different checkpoint inhibitors and which ones patients should be treated with and what the surgeon should be thinking about vis-a-vis immune checkpoint inhibitors for melanoma?
Totally. I think the main two to kind of get your head around are anti-PD-1 and anti-CTLA-4. And so, there's Pembro, Nivo are sort of drug names of anti-PD-1, Ipi, ipilimumab, and others of anti-CTLA-4. And then there's a whole bunch of new ones, LAG-3, TIM-3, but I think you could get into alphabet soup and probably not so helpful. I think the main two classes are the anti-PD-1, which really works at the level of the tumor to kind of reactivate T cells that might have gotten to the tumor, but have sort of been turned off locally and aren't doing their job. Anti-CTLA-4 works kind of upstream of that to try to help traffic some cells, in theory, to the tumor. And they have different side effect profiles. And so we still don't know exactly why they work in certain situations or another, but I think some easy ones are the combination, which is much more toxic, is the right one for brain mets, anyone who has brain mets. And then in the neoadjuvant setting, we are using combos, but at lower doses to try to mitigate that toxicity. And then I think PD-1, the sort of anti-PD-1, is going to be a backbone of a lot of future combinations because it's kind of best bang for your buck with the least amount of toxicity. So I think like looking forward, many things are going to build off of that backbone because it's just much less toxic.
Yeah, that makes sense. So maybe if we could just expand on that conversation into the BRAF and the MEK inhibitors, right? You had talked a lot about the immune checkpoint inhibitors, but what about patients who have BRAF mutations? Can you talk to us a little bit about, targeting BRAF, targeting the MEK pathway? When should these be used as monotherapy? When are they used as combined therapy? What does the data show?
Yeah, so actually we only ever use them nowadays as combo. They were initially used as mono, and it's one of the few times where the monotherapy actually had more side effects than the combo. The combo actually mitigates some of the secondary side effects. So it's more efficacious and fewer side effects when we use the combo. So we always do it. There's newer combos, like newer actual drugs that have different side effect profiles, but they're, again, BRAF MEK is used together. And it's hitting the same pathway, just at different places along the way. They're only efficacious in patients who have a BRAF mutation. That's about half of our patients. They tend to be younger. Historically, it tended to be more aggressive disease, but now with having a new therapy for that type, say it kind of evens out. And really, we only use it after immune therapy has failed or in patients who have rapidly progressing disease that don't have the time to wait because immunotherapy takes a while to actually work, or in the adjuvant setting. They're still approved for adjuvant stage 3.
Can we talk a little bit more about the indication for these drugs? Obviously in metastatic disease, but what about in the adjuvant setting? Before we move on to Dr. Hingstrom's paper on neoadjuvant, maybe you can crystallize for our listeners, when are these drugs indicated in the adjuvant setting?
Yeah, of course. And it's sort of a little bit out of order in terms of when things were approved, but there are adjuvant approvals for PD-1 monotherapy. So by itself in high risk stage 2. So non-nodal disease, but high risk primaries where the patients are pretty high risk of visceral disease. There's anti-PD-1 is approved. I would say it's not always used because it can be toxic, but that is a group that has an approval. In stage 3, resected or oligometastatic stage 4, the choices are anti-PD-1 monotherapy or BRAF MEK if you have a BRAF mutation. And there's not a lot of data on who should get what. There's some emerging data, that perhaps, one might be better, but there's never been a head-to-head combo. So there's a lot of equipoise on a BRAF mutant patient in a stage 3 adjuvant setting, whether they should get targeted therapy or immunotherapy. I think most people would give them immunotherapy, but at my home institution for the lower burden disease, we actually would probably start with targeted.
Great. So, kind of now the pivot to the neoadjuvant setting. One of the other articles in this issue of Surgical Oncology Clinics is the one by Dr. Hingstrom, talking about neoadjuvant therapy and the changes in the management of macroscopic stage 3 and resectable stage 4 melanoma. So, can you provide some insight into the evolution of thinking as it relates to neoadjuvant therapy? What are the indications? And what are some of the kind of preferred approaches by surgeons and medical oncologists?
So this is one of my favorite topics. And the reason is because all of us are familiar with neoadjuvant, I think, in training in the setting of chemo regimens for the most part. And you can think about rectal cancer to do sphincter preservation and defer a permanent ostomy, or in breast, where often we were using it for tumor shrinkage to do a lumpectomy, not a mastectomy. In immunotherapy, the shrinkage of the tumor is not predictable, and surgical resection is not really often on the borderline setting. So really, the reason we're using immunotherapy in the neoadjuvant setting is completely different than I think historically why we would use it, which would be to decrease the morbidity of surgery. In fact, we're using it to expose the body's immune system to the full complement of the tumor, to actually train it against all of the badness that is the tumor before you resect it, as opposed to trying to train it against the drugs that might be left behind afterwards, which would be giving it in the adjuvant setting. So it's fundamentally different in terms of the rationale, and there's data, both patient level data and preclinical data, supporting that idea that you get a better and more durable response, but certainly a broader response of the immune system. It's like creating like little soldiers that can fight the tumor against all of the facets of the tumor. So it's a really interesting concept that I think is different.
Right. Well, and to that point, like when you do the resection, can you maybe highlight for us how often do you see like a path complete response? And does the response in the local tumor kind of dictate prognosis because, the response was better in the local tumor, so then the body has been better trained, so to speak, to attack the occult disease with the immune response that you've kind of primed by using neoadjuvant therapy?
Yes, another major reason why this is so interesting is we have a relatively quick turnaround time to assess pathologic response. So each patient is tested and, with these drugs, not tested, but treated with, and we can assess with the pathologic response. So with PD-1 monotherapy, the pathologic response rates are about 30-ish%. And with ipi-nivo combos, which again is a different dosing regimen, it's about 50%. And so it's been very interesting because we know that pathologic response, so if you have a major path response or a complete path response, so less than 10% viable tumor at the time of surgery, that corresponds with a great RFS or recurrence-free survival. And so in the second trial, the NADINA trial, they actually used pathologic response to de-escalate additional adjuvant therapy. So if you had a path CR or a near path CR, less than 10% viable tumor, you could forego adjuvant immunotherapy when you would get the combo up front. That was not the case in the trials with the PD-1 monotherapy, although people are riffing on that idea. But it's this idea of sort of patient-derived, personalized decision-making in that setting. So it's very appealing to patients.
Till now, we've been talking largely about systemic therapy, systemic, adjuvant, systemic neoadjuvant. The other point that Dr. Hannestrom touches on is this concept of intralesional neoadjuvant immunotherapy. And I know in melanoma, there's a long history of kind of interlesional treatment. So where do we kind of stand now with interlesional therapy, interlesional neoadjuvant immunotherapy? What's the indications for that versus systemic neoadjuvant therapy? Can you shine some light on that?
Yeah, I think in the neoadjuvant place, people are very excited about neoadjuvant trials because they call them window of opportunity. You can kind of give a treatment and then see how it's doing biologically. There are no neoadjuvant indications for interlesional therapy, but there's a great amount of interest in adding them into the regimen. There have been some trials run, but I would say like in terms of like approved agents, but the interlesional therapies are used quite a bit in melanoma. Again, anecdotally, that used to work. It's going back to the Coley's toxins, injecting heat inactivated bacteria in tumors and watching them shrink. But now these are oncolytic viruses. So TVEC is one of the approved oncolytic virus. There's a whole bunch of things in the pipeline in these injectable space, but it's the idea of hopefully kicking off an abscopal effect. If you plant a seed, get the tumor to lyse in the setting of immune activation, maybe you can kind of wake up the immune system there at the site of the tumor, but also hopefully and additional other sites. And that's what people get very excited about. And that's why they're likely not going to work great on their own, but may work very well in the setting of immune checkpoint inhibitors. There are some types of melanoma, like in transit disease, that are very amenable to these intralesional approaches because they're like very diffuse, but local regional spread. And other places like the head and neck, where it's just really hard to get a good clean resection. So there are some tumor types that are more amenable to that.
Right. So, in our conversation, I've heard words like it may work, there may be a response. Obviously this is a heterogeneous population. Maybe we can move on and talk about, how can we identify better people who are going to be responders? And the article by Dr. Wagner, specifically talks about predictive biomarkers of immune checkpoint inhibitor therapy. Many biomarker-related clinical trials in melanoma have focused on prognostic rather than predictive biomarkers. But I think many of us want a biomarker that's going to be predictive of who will respond to this therapy and who will not be responsive to this therapy. So maybe just highlight a little bit where we stand with predictive biomarkers with ICI therapy in melanoma.
So in
Great. Well,
melanoma, there's no clean biomarker. I mean, it's a holy grail, and there's a lot of work that's been done in this space, and there's a whole bunch of reasons why it hasn't panned out to be so clean. So PD-L1 as a biomarker, which is used in stratification in lung cancer, is not used in melanoma. It doesn't perform well. There's been a great deal of interest. Tumor mutational burden. We know tumors that have a bunch of mutations have a lot more neoantigens or proteins that your body can detect as not self. It correlates with, but is not predictive of immune checkpoint inhibitor response. So we look at UV signature, and it again correlates with, but is not predictive of. So in colorectal cancer or rectal cancer, MSI high status, patients who have DNA mismatch repair issues are pretty reliably going to respond to immune checkpoint inhibitors, and there's a biology to that. So I think in melanoma we have a lot of surrogate correlative markers, but we have to kind of use them as a sort of gamish and take a little bit of data here and there to try to make the most informed decision. I wish we had really clean, companion diagnostics and biomarkers, but unfortunately we're left with sort of collecting as much data as we can and then kind of integrating it to make the best decision on a case-by-case basis.
what about ctDNA? In my world of colorectal surgery and HPV, there's a lot of buzz about ctDNA. Is that being used in melanoma to assess, response and, with, immune checkpoint inhibitors, BRAF inhibitors, to see if there's a change in the ctDNA levels pre-post treatment? Great.
Yeah, there's a lot of work that's been done, and there's a lot of data that's suggestive that it, in other diseases, correlates with minimal residual disease, so persistence of tumor after surgery when it shouldn't be there anymore, or some of these other things. It's not standardly used. It's not in the NCCN, but I would say that probably more frequently people are using it. And I think there's, places like neoadjuvant where a path CR can de-escalate, but what if you have a partial response, right? Those are places where we're looking for additional data points. And so ctDNA could be very useful there. And I think there's emerging data that might be useful. So I'd say ctDNA is incredibly useful. Many places are checking it, but it certainly hasn't been codified into a framework of, how everyone should practice. But looking to the future, I think we certainly will be using it in those places where you're trying to, again, glean an additional bit of information to make a wise decision.
Great. Now I want to move on. We've been largely talking about BRAF inhibitors, MEK inhibitors, immune checkpoint inhibitors. What about this article by Dr. Chick, Bean, and Contreras about adoptive T-cell therapy and melanoma? Where do we stand with TIL therapy for metastatic melanoma, and how does it fit into the therapeutic algorithm or therapeutic hierarchy when treating patients with metastatic disease?
Yeah, I mean, we just have to pay homage to Steve Rosenberg at the NIH, an awesome surgeon scientist who really championed this field almost 40 years ago and really showed that this can work. And I'll just sort of quickly say, this is when we cut out a tumor to, extract T cells that recognize the tumor that maybe aren't doing their job so well, to like supercharge them and expand them and then give them back after lymphodepleting chemo and with IL-2, but as a living drug back to the patient. So it's their own autologous material. And really championed by Steve Rosenberg. The problem with the operations of doing that at a place other than the NIH was very challenging. And so companies have filled that gap to kind of help with the process offload. But the concept's actually been around for a while. So in 2024, in February, the FDA approved first-in-class adoptive cell therapy, that can be broadly delivered anywhere as second-line therapy in advanced stage 4 melanoma. The trial results about 30% response rate, which in second line failed, immunotherapy failed patients or BRAF targeted therapy failed patients, was actually pretty good. And the real world data is looking not as great, but there was a backlog of really sick patients who were waiting around with not many good options who got TIL who probably weren't optimal. So I think looking to the future, what many people are trying to do if they're interested in TIL as a program is thinking about more rapid transition. It's probably better if you're not getting efficacy from one therapy to switch to the next one much more quickly before the tumor has a chance to become really ugly and bad biology. And there's clear data to support that. So I think at our institution and actually many others, people are really thinking about that, anticipating what might happen so that if it's not working, you're set up, because there is a process issue until there's a delay. You have to resect the tumor, you have to wait for the T cells. And in patients who are very sick, they may not have time. So I think we're all looking ahead as to how to optimize this and get it used in patients when they're in a better physical condition.
Yeah, I think that point is well highlighted in the article, just the logistics and the role that surgeons have to play in kind of processing this to get the TILs. So you had mentioned that that some of the data showed an objective response rate of about 36%, 36%. How durable are these responses? I know Dr. Rosenberg has shown some great CRs that have been durable. Are these anecdotal, or in your practice, have you seen patients have durable CRs from TIL therapy? Great.
No, I
Well,
think when they're real, they're durable. I don't think it's anecdotal, but I do think there's attrition. And so I think with the curves, we haven't had a long enough time horizon, right? The phase 3 read out and the FDA approval is 2024 with this new kind of iteration. But I think looking at the Steve Rosenberg data and others, I think patients who get a real response probably have a durable response. So I think it's a really great option. I would say anecdotally, we have a few success stories already that are really, really heartening, and I think really help everyone kind of buy into it. But I think that's not everybody. And I think patient selection, patient optimization, and improvement of the product are going to be really important in doing this better in the future.
well, this has been a great conversation, Dr. Bowl, and I wanted to kind of leave you with the last word. If there were any, particular pearls that you thought were important for surgeons who take care of patients with melanoma that take away from this issue of surgical clinics, surgical oncology clinics.
Well, no,
Great. Well,
thank you. This has been great. I mean, I think it's just an emerging field. And so I think anyone who does this and is very serious about it, should become a part of the community, get really actively involved, because I think we're all pushing the needle as a field. And so I think there's a lot of room for improvement. There's a lot of room for creativity. But I would say one of the things I like is sort of the cohesion in the field of really thinking about how to move the needle. And I think that really includes surgery as a really key modality in how to do this better.
great. Well, again, thank you, Dr. Bolin, and thank all of the authors that contributed to this issue on melanoma. It's really world-class issue, and I hope that our listeners enjoyed the podcast, and we'll take a deeper dive into the issue itself to get more details on the state-of-the-art treatment of patients with melanoma. So thanks again.
Great. Thank you so much.
Thanks for joining us for this episode of the Surgical Oncology Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on melanoma, please visit us.elsevierhealth.com/expert. Surgical Oncology Clinics is available for individual print subscriptions with online access or as an online-only subscription. The series is also accessible via Elsevier's platforms, Clinical Key and Science Direct. For more information about this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Don't forget to follow us on Twitter and subscribe to the Surgical Oncology Clinics podcast. Thanks for listening.